Now that we've explored and illustrated the specific areas of where we have language centers on the lateral aspect of the left hemisphere, let's talk about specific lesions that involve them and what other signs and symptoms might be evident in this hypothetical patient. So the global term for a disorder of language is an aphasia. And as we will see here, we will have different forms of aphasias depending on whether we've lesioned Broca's area, Wernicke's area, the angular gyrus, and as we will see, if we lesion a fiber bundle that's connecting language centers in the lateral aspect of the hemisphere. So first off, we know that Broca's area is situated directly anterior to where we find the corticobulbar neurons that provide the bilateral innervation to lower motor neurons and cranial nerve nuclei to change the position of skeletal muscles in the palate, pharynx, and particularly the larynx to generate intelligible speech in complete sentences. So the motor area of Broca's area corresponds to a numerical classification provided by Brodmann in the early 1900s. He came up with, I think, 50 different cortical areas based on differences in their histologic structure in a monkey brain. And Brodmann numbers are sometimes used as synonyms for functionally specific cortical areas, but it seems that when Brodmann areas are used, they are most frequently associated or used as synonyms for functionally specific language center areas, including Broca's area, which is considered to be areas 44 and 45 in the left frontal lobe. So what kind of signs and symptoms result when we have damage to Broca's area? So before we allude to that, let me illustrate the features at the box at the top of the page. Note that more than one aphasia will have some common signs and symptoms. More than one aphasia might disrupt the patient's ability to communicate in writing. So they may also develop dys or agraphia, regardless of handedness, certainly more prominently involving the right hand than the left hand. And then a common feature to aphasias that we'll explore in a little more detail is an impaired ability by the patient with an aphasia to repeat or answer simple verbal questions when asked to do so by the examiner. So one way to test the inability to repeat is to have the examiner ask a hypothetical patient whom they suspect of having an aphasia to count backwards from 10 to 1, 10, 9, 8, 7, 6, 5, or to ask them to repeat a nonsensical phrase such as no, ifs, ands, or buts. Certainly, for a normal individual to produce or perform this motor task, they have to hear the request, auditory cortex. They have to understand the request by having normal neurons in Wernicke's areas, and they have to be able to produce the motor response to the request by having an intact Broca's area. So what actual kind of aphasia do we see when we have a lesion in Broca's area? Well, the easy way would be to describe it as being a Broca's aphasia, but classically neurologists describe a lesion to Broca's area as producing a motor, a non-fluent, or as we say at the top of the slide, an expressive aphasia. What does this mean? What is this patient's language center disorder? They have a very difficult time speaking in complete sentences, giving them what's called a non-fluent aphasia. So these patients are not mute. In other words, their verbal output is not reduced to nothing, but they can simply respond to verbal questions by only utilizing mainly single syllable words in response to a verbal question that they fully understand. So corollaries to this is certainly this patient, since Wernicke's area is intact and the angular gyrus intact, language comprehension is intact, so they understand everything that's being said to them, but their verbal output in response to questions, or even when speaking spontaneously about what's going on in their visual and somatosensory world, is severely reduced to the use of single syllable words. So, and again, as we've alluded to, these patients with an expressive aphasia lesion to Broca's area also have dys or agraphia, which we said is a common attribute of more than one of aphasias we will see going forward. And certainly the patient's ability to answer a verbal question is severely impaired by the lack of the ability to formulate an adequate motor response to a question that they fully understand. And this condition classically results in or makes the patient keenly aware and frustrated by their expressive aphasia because they hear and understand everything that's being asked of them. The examiner says, can you count backwards from 10 to 1? They will hear and understand the question, but they can't verbalize an adequate motor response to a question that they fully understand, nor can they express an answer to the question in writing. And they're extremely aware of and frustrated, therefore, by their expressive aphasia. Then, because of its proximity, it would be not unusual for a patient with Broca's aphasia, as well as a patient with a frontal eye field lesion, to have involvement of the adjacent primary motor cortex. So since Broca's area is in the left side, this patient would develop a right lower face weakness and a right upper limb weakness as a logical corollary if branches of the middle cerebral artery to the adjacent area of primary motor cortex are also involved. And again, that's the point that we make here. And the weakness would certainly have to be of a spastic upper motor neuron disorder. And again, the limb that's specifically affected can only be the right upper limb and the right lower face, because Broca's area is situated immediately adjacent to the upper motor neurons in the left hemisphere that are innervating lower motor neurons contralaterally. Then, how is a receptive, a sensory, or a fluent aphasia different than a Broca's aphasia? This is now classically associated with a lesion to Wernicke's area in the left or dominant parietal lobe in a Brodmann area that is associated with area 22. So the specific lesion involving Wernicke's area gives rise to a patient that now cannot understand what has been said to them. And as we will see, if the lesion expands out to the left parietal lobe where we find the angular gyrus, the patient may not also be able to understand what they read. They will have a form of alexia. So let's simply talk specifically first about Wernicke's aphasia. It's known synonymously as a fluent or a receptive or a sensory aphasia because in this particular individual, the speech output is relatively fluent. In other words, they can speak in relatively complete sentences, but frequently the fluent verbalization lacks meaning. They substitute or misuse words in the normal context of visual speech, even though they can speak spontaneously about what's going on in their visual and somatosensory world. So when they misuse words, these patients are considered to be paraphasic. And frequently neurologists describe this as patients speaking in the form of a word salad, as if you went through a salad bar and simply picked out random terms and attempted to use them in a complete sentence, in a sentence that really seems to be fluent but lacks an appropriate meaning. So these patients then, since they cannot understand what is being said to them, their problem on the repetitive side is one where if you ask this patient to repeat the nonsensical phrase no, ifs, ands, or buts, they would not verbalize a response at all because they don't understand the command in the first place. And in contrast to a patient with a Broca's aphasia, these patients are generally unaware and or not distressed as a result of this condition. And frequently these patients just simply think they need to get hearing aids because their hearing's involved. Now, that's logical because more than likely the Wernicke's aphasia lesion in the left temporal lobe probably also does involve primary auditory cortex. So it's very likely that this patient does have a bilateral sensory neural hearing loss, but in addition, when the involvement involves Wernicke's area, they do not understand what they have heard, even though in most cases the individual is speaking loud enough for them to hear. So they just think they have a hearing problem, they need to get a hearing aid, but it's more than that. They do not understand what the individual is saying to them, and they tend to ignore them because they think they simply have a hearing problem. So then, what if the lesion actually does extend back into the left parietal lobe and includes the area of the angular gyrus, which is identified by Brodmann as area 39? So this is where we have our written comprehension center, where the patient develops a form of alexia, where they do not understand written language. And since the decreased ability to write is affected in more than one aphasia, we classically say that this patient with a dominant parietal lobe angular gyrus lesion presents with alexia and agraphia. But since Wernicke's area is unaffected, their ability to understand spoken language may still be preserved. So then, these signs and symptoms directly attributable to an angular gyrus lesion that include alexia and agraphia may also involve adjacent somatosensory association cortical areas, where the same patient might develop additional signs and symptoms associated with the involvement of the adjacent somatosensory association cortex. So the same patient may develop a phenomenon known as finger agnosia. Again, agnosia is a higher order somatosensory deficit where a patient can still feel three-dimensional objects with the fingers of the right hand, but when asked to point specifically to the index finger or the middle finger of the right hand, they are unable to do that because they have lack of specific finger recognition, finger agnosia. The same patient also develops or dyscalculia, where they can't solve simple math problems. They can no longer add and subtract simple numbers, and it's thought that this area of the left parietal lobe is what we call the simple math part of your brain. And again, it's somewhat logical, so neurologists think, that the finger agnosia is closely tied with dyscalculia, because when children first start to count from 1 to 5, they use the thumb and fingers of a respective hand, probably the hand dominant for handedness, which will be the right one. So this constellation of deficits constitutes Gerstmann syndrome. So Gerstmann syndrome at a minimum may have alexia and agraphia with the angular gyrus lesion, but additional signs and symptoms can also be seen in this left parietal lobe involvement that include finger agnosia, dyscalculia, and maybe some right-left disorientation as well. So this constellation of deficits underscores this area, as we said, is probably involved in the simple math portion of the hemisphere, and how children, when they initially begin to count from 1 to 5, they generally use their fingers, which is probably the corollary tie-in between a common cortical lesion area that produces both finger agnosia and dys or acalculia. Then, let's revisit a small image of the lateral view of the hemisphere that we talked about extensively. And the additional point we want to make on this slide is to say that language centers in the lateral aspect of the hemisphere are logically going to be connected to one another. And what is providing the connection mainly between language comprehension and motor speech is a fiber bundle that's called either the superior longitudinal or the arcuate fasciculus. Arcuate fasciculus because it's a slightly arch-shaped fiber bundle. So this fiber bundle logically connects language comprehension centers that are back in the temporal and the parietal lobe with motor speech centers up here in Broca's area, allowing us or giving us the appropriate neural connections that give us the ability simply to repeat after an examiner and to provide a verbal answer to an examiner's question. So a lesion of this individual structure, just a lesion to the arcuate fasciculus, leaving the other language centers intact, produces or results in what is known as a conduction aphasia. So think about what the different neurologic signs and symptoms of this patient will be. In this patient, since Broca's area is fine, the patient's verbal output is relatively fluent, but they tend to misuse words, as we saw in a patient with Wernicke's aphasia. But since Wernicke's area is also intact, as we will see in a moment, the patient's ability to hear and understand verbal communication is also normal, because Wernicke's area is intact, and the patient will have no problems interpreting what they read on a hypothetical page. So this is an example of a disconnect syndrome, as we will see on the next slide, where the language centers are intact, and really the patient's ability in terms of language function means that they cannot respond verbally to a question or a request that they fully understand. And just extending this conversation, because Wernicke's area and the angular gyrus are normal, oral and written comprehension are normal. But if asked to, the patient cannot repeat words or execute verbal commands, such as the examiner asking them, can you count backwards beginning at 100? Can you repeat the nonsensical phrase, no ifs, ands, or buts? And they also demonstrate poor object naming. Even though they have a conscious awareness of what the object is, they cannot verbalize the identity of the object because of the disconnection between language comprehension and the motor response to the verbal request. So this is, as we said, an example of a disconnect syndrome in which we have not lesioned a functionally specific cortical area, a language center, but we've disconnected language comprehension centers from motor speech centers in this particular example. So what's similar about this patient, as was the one with an expressive aphasia, these patients are keenly aware and frustrated by their inability to execute or answer a verbal command that they fully understand. And they're probably even more frustrated than one with an expressive aphasia because their verbal output is relatively fluent, even though it is probably paraphasic. Now then, let's move to lesions that might involve the non-dominant or the left hemisphere. And again, we've spoken earlier, if we outline this, we can see again the tongue-like temporal lobe that's there, and we see the central sulcus that's there. So previously, we've illustrated the significance and the locations of emotional content centers that are located in the lateral aspect of the right hemisphere. An emotional content center there that gives us the ability to add an emotional content to speech, and an area equivalent to Wernicke's area in the left hemisphere that gave us the ability to understand the emotional content of someone else's speech. These could be the result of isolated lesions in the right hemisphere in areas that are equivalent to Broca's and Wernicke's. But now, what if we have a lesion in the right parietal lobe in the area where we found the angular gyrus in the opposite side? So if we lesion the right parietal lobe in the non-dominant hemisphere, we don't get Gerstmann syndrome. What is created is an interesting neurologic phenomenon known as unilateral neglect or asomatignosia, which means that this individual no longer recognizes their own body parts. They no longer recognize left side body parts because the lesion is in the right or the non-dominant parietal lobe. So this individual, if we specialize it out here, where the right parietal lobe is the site where we are integrating visual and somatosensory information. It's a key area where we form the overall body image, particularly that of the left side of visual and somatosensory space. So this lesion in the non-dominant or the right parietal lobe can result in what is called an unawareness or a neglect of the contralateral half of the body, known as asomatic but the part of the body that's always neglected is the left side of the body, and we'll see the manifestations of this going forward. So this is a higher order somatosensory deficit where the patient can still feel a stimulus that's generated on the left side of the body, but regardless of that, the patients tend to ignore left side body parts. They may fail to dress or undress the upper or the lower limb. Females may no longer put makeup on the left side of their face. Involved males may no longer shave the left side of their face. They may no longer recognize their left hand as belonging to them because they have a classic left side hemi-neglect and asomatic nausea of left side body parts. So this lesion doesn't produce any visual field deficits, although the parietal lobe component of the visual radiations might be involved. So the patient's visual fields are intact, but again, they no longer recognize what they are seeing in the left side of visual space because of the unilateral neglect associated with this parietal or non-dominant parietal lesion. So classic tests for this: if you were to present this patient with a horizontal line right there and ask them to bisect the line, you and I would make a pretty good job of bisecting it approximately in the middle. A patient with unilateral neglect will bisect only the right half of the line because they don't think that the left half of the line exists. Then the classic test for this is to ask the patient to draw numbers on a clock face. You and I would make an attempt, probably a good one, to draw the adequate numbers, but a patient with unilateral neglect is only going to draw the numbers on the right half of the clock face because they don't think that the left half of the clock face exists. Classic sign and manifestation of a patient with unilateral neglect. And again, this patient is going to deny or ignore the fact that their left arm or leg belongs to them, even though the left arm or leg may be brought into an area of visual space where they can adequately see the object. And lastly, very common in any individual that has a cortical neurological feature, the patient is going to deny their deficit, much like a patient might deny their existence of Wernicke's aphasia because no one wants to admit to anyone that they have a neurologic disorder. So these signs and symptoms are classically pathognomonic of just a right or a non-dominant parietal lobe lesion that causes not Gerstmann syndrome, which we saw in the left side lesion, but unilateral neglect associated with asomatic nausea.